Okay, hello everyone. Happy Friday. So we made it through yet another week, and I can't wait until Thanksgiving because we get a break. Or actually, I hope you enjoyed yesterday. Happy Veterans Day to all our veterans in the class, and if you have loved ones that are veterans as well, like happy belated Veterans Day. I wish we had. This is why like October is tough because it doesn't really have holidays. Maybe we can ask like if we can make Native and Indigenous Peoples Day on October, but I love November because of all the holidays and we get more breaks. But okay, let's try to finish up. I think we have one more peripheral nervous system lecture after this, so I'm going to save cranial nerves for the next lecture. So today I'm going to talk all about reflexes. And before I get to talk about reflexes, let's finish up with the plexuses. Now, do I expect you to know everything about all the plexuses and expect you to know all of these structures? Not really, but I want you to, at this level, it doesn't hurt. And especially if you plan on going into physical therapy, for sure, you need to know this. Or if you're going into anything involving orthopedics, yeah, you definitely have to know your nerve anatomy for sure, or neurology. But what's showing is like all these nerves and branches, they all are a big complex network. They interweave with each other. It's not just linear strands. And they have these roots that are these spinal nerves that emerge from your spinal cord. Again, we didn't talk about the spinal cord in detail yet, but I'm just letting you know this is where it connects your peripheral nervous system to your central nervous system. Now, over here, we have like some of the major branches and nerves of the brachial plexus, and one of the major nerves is the median nerve. So notice that the median nerve actually is supplied by multiple roots here. So 4 out of the 5 roots of the brachial plexus supply the median nerve, and they all fuse here. So if you have like a lesion up here, well, you'll still get sensation and still get some sort of motor control, but this is how important the median nerve is. It's not coincidental that has multiple roots supplying it, because again, why is it good to have multiple roots? If one of the roots gets cut off or has a lesion in it, then you still have other roots that can still provide sensation and control of the downstream nerves. Now what we have is like, okay, so what does the median nerve control and why is it so important? Well, as you can see here, it controls many of the flexors of the forearm in terms of motor control. So what happens when you flex things like your digits over here or your wrist? Well, it's going to flex things, right? So it's going to involve grabbing onto things and flexing things. Now, there's something called that might be very familiar to you called the carpal tunnel. So you probably have heard carpal tunnel syndrome sometime during your life, right? So what is the carpal tunnel? Well, now we know what our carpal bones are, right? Our wrist bones. But what is the carpal tunnel? So the tunnel, you think of tunnel as something's passing through something, and that's what it is. So here we have our carpal bones, and this is like if you took someone's arm or hand and they kind of cut it off and looked at their hand like this. So you would see the carpal bones, but notice that it's kind of forming like the bottom and walls of the structure over here. And here's a cross section of the median nerve. And across the median, or actually across the carpal bones, what we have is something called the transverse carpal ligament. So it kind of forms like a roof over here. It kind of spans it. So notice that the carpal bones form most of the carpal tunnel, but you also have a ligament that spans it and forms the entire structure that this median nerve and other tendons can pass through. So a lot of the deep tendons that help to move your wrist and fingers, yeah, that passes through this carpal tunnel. Now, what's carpal tunnel syndrome? Well, something happens to the carpal tunnel, right? So what we have here is that this median nerve, this is in the healthy, normal cross-section, but in this diagram, you see the median nerve is compressed. And if you remember our talk about intervertebral joints, like what happens when we have our bulging discs or herniated discs? That presses on the nerve, and when nerves are pressed, they're kind of like us. When we get pressed, we have pain, right? Same with nerves. When nerves are pressed, can become compressed, they have sometimes loss of sensation, sometimes they have pain. So this is why people who have carpal tunnel syndrome, they have this sometimes they say it's numbness, sometimes they can't feel it, sometimes they say it's searing pain that shoots up their arm. Well, it's from this median nerve being having some sort of trauma due to, or should I use trauma, or say the median nerve is most common cause of it is median nerve compression. Now, remember that these nerves, again, the big exception is that C1 spinal nerve. That one is mostly motor, but pretty much all the other spinal nerves in your body are both motor and sensory. So the thing is that it's not just about control via the median nerve. Your median nerve also carries sensation. So that's why people have with the carpal tunnel syndrome, they have this numbness, tingling, pain. This is common because they are all sensations, and they're also general sensations or a lack of general senses. So this is why the people who have that, they often feel those symptoms. But remember, that's the sensory part. But what about loss of grip? Well, in the previous slide, I told you had a list of muscles that the median nerve compress or innervates. So a lot of these help with flexion and especially of your finger joints as well. So a loss of grip is common because if you're starting to affect the motor function of the median nerve, you also affect the control of those muscles that help to grip on things. So if you're kind of compressing it and interfering with the median nerve function, that affects your grip strength. And median nerve, again, this is why I brought up that little innervation chart. So it's showing you not just the sensation, but also the motor control. So if you have some sort of loss or reduction in your conduction of the median nerve, well, that's going to also affect all the muscles that help to move these parts right here. So 3.5 fingers. Yeah, it's kind of interesting, your ring finger, that's kind of like both median and ulnar. So many causes, but with carpal tunnel syndrome, many things can cause it, not just compression, but they all involve the median nerve. Okay, and let's see. Oh, and I love this chart. There's many things telling you about, and this is why they have so many ergonomic ways, or have you ever, I don't have my ergonomic mouse with me right now, but this is why they say, if you, for typing, they say do not type like this, or don't type like this, because why? Well, notice that these blue dashed lines kind of follow the tracings of where your median nerve would pass through, because again, your median nerve has to pass through that carpal tunnel. So if it's going this way and branching this way, what happens when you're kind of bending it this way, or this way, or this way when you're using your mouse or keyboard? You're kind of putting a kink in the hose, and remember, your nerves don't like being compressed. So if you continually do this and apply stresses to and compression to these nerves, that causes these nerves to feel that all the symptoms associated with reduced or unusual sensations, or also loss of grip and motor control as well. So this is why with this right ergonomics, they're trying to keep that median nerve aligned with your carpal tunnel, so you're not really compressing it by bending it this way and that way repeatedly. So how do you diagnose carpal tunnel syndrome? Well, you can do it via electromyography. And you really be like, whoa, that's a big complex word, but electro sounds like electricity. Myo meaning muscles, and graphy means they're graphing, they're measuring it. So the cool thing is that they're able to apply small current and detect how quickly that current conducts along the tissues between these two electrodes. So what they do with electromyography is they detect, okay, is there some sort of abnormal conduction speed? And if they see it's different from abnormal, maybe there is some sort of nerve pathology and damage occurring along that nerve. So notice that they're trying to make it along that median nerve, and also have all these electrodes that help to kind of register how fast these signals travel. And then there's also something called Tinel sign, and this is why I miss lecturing in person, because sometimes I would do if people have carpal tunnel syndrome, again, it's not a thing, I can't officially diagnose anybody or whatnot, I'm not licensed to do that right now. But what you kind of do is if you've ever been screened for carpal tunnel syndrome, they may have done something they tap your wrist. And it's kind of funny, if maybe out of 3 people, every class, there would be somebody where they can't be kind of like that. And I'm like, oh, do you use the keyboard a lot? Or one of them was she played the piano a lot, and it was kind of amazing seeing how much she reacted. She's like, oh, it felt like my whole arm went numb. And again, where does that median nerve run? It runs all the way down here to your fingers, right? So that sensation was shooting up all the way that nerve and causing her whole arm to feel numb. So there's multiple ways. There's a physical exam, but there's also ways to measure it directly. So how do you fix that carpal tunnel surgery? Well, what you can do is do something about that ligament. So here we have the median nerve is compressed, it's being squished. So what's the way to prevent something from getting a lot of pressure is to release the pressure. So one way you can release the pressure is to use surgery. So I think there's other names for the carpal tunnel, but like, oh yeah, flexor retinaculum. That's the one that I think the Martini book likes to use that one, but I like transverse carpal ligament because what is it? It's, remember, transverse is like horizontal and across. Carpal, wrist, ligament. It connects bone to bone. So this is why I love this one. So you should know both, but I love using transverse carpal ligament because it tells you exactly where it is. And oh yeah, if you don't, sorry if you're kind of squeamish about surgery, but they used to do it where they almost open up the whole hand. And this, luckily, they're able to kind of modify it, and like, so you don't have to open up the whole area. And because it used to take like weeks for recovery, according to my friends and who've had this surgery, they say like, you're out of work. If you do anything with your hands, you're out of work for a few weeks. But what's the whole purpose? Well, if that transverse carpal ligament is pressing that nerve, maybe you can cut that ligament, and this is why you're going to be out of work for a while, and let that ligament heal so that instead of being compressed, then it can regrow, mesh again, and then now you have more room and that median nerve is no longer being compressed. But that's also why there are variable results. Sometimes when the transverse carpal ligament anneals and heals again, then sometimes it doesn't give enough room. So that's why some people like, oh yeah, it feels like new again. Or sometimes they're like, yeah, it kind of felt better, but I'm back to the same symptoms. And maybe their ligament just grew almost at the same tightness and gave very little room back to the median nerve. So that might be another part as well. Yep. Okay, so let's see, that was carpal tunnel syndrome. Okay, let's talk about the other ones as well. Okay, so transfer. Okay. All right. So here's the lumbar plexus, and in lumbar plexus, again, it's named after that lumbar region, that lower back, right? So what we have here are, now do I want you to know the spinal segments? Not really, right? And for the nerves and the distribution, what I want you to focus on for these is that focus more on the nerves that are branches of this. So this, like things like iliohypogastric, and hey, where's the hypogastric region? That was the one that's kind of like the pubic region, right? And then we also have our ilioinguinal. So ilio sounds like ilium, and it's derived from that, and inguinal referring to the inguinal regions, right? Genital femoral, lateral femoral, cutaneous, femoral. So they all kind of tell you like, hey, this is in the lower body somewhere. Obturator, what does that sound like? Well, remember that obturator foramen in the pelvis? So that's where it's named after. And where do you think it passes through? Remember, when you have some sort of opening, usually it's making room for something to pass through. So this is why if you pay attention and you know those bone markings very well, it pays off with the muscles, pays off with the nerves. And then there's the sacral plexus. So again, notice that there is some common roots and common trunks, but what happens is that we have it's a little lower overall, but what do we have? The gluteals, where do you find your glutes? How about your femur? And yeah, that's why sometimes it's also called the lumbosacral plexus, because here we have the lateral femoral cutaneous and the lumbar plexus. And here we have the posterior femoral cutaneous. So when you look at this plexus and put those two together, they kind of interweave. So that's why I can see why some groups and textbooks consider it one huge plexus. And then the sciatic nerve and pudendal nerve. And the sciatic nerve, so where do you think that is? The sciatic nerve is, remember that we had those greater and lesser sciatic notches? So that's probably going to pass through one of those notches, right? And pudendal is interesting as well. So pudendal comes from, if I recall correctly, a Latin term meaning shameful or ashamed. And this is very important because the pudendal nerve actually innervates your genital, like many of your genitalia, and also like the anus, and also so the genitalia. So they often involved in the private regions, and also in urination and defecation. So that's why they say called the shameful nerve, because it involves those very sensitive areas. But does that mean it's like not important? It's super important, because if you lose your ability to use control when you go to the bathroom, I mean, that means like if you have damage to this nerve, these people become incontinent, so they are unable to hold and maintain their functions as well. Sciatic nerve is also important because it's like if you ever get the chance to do, if you go to med school or if you go to physical therapy school or maybe any other sort of allied health school where you're able to do a dissection, the sciatic nerve is like the easiest. You can't miss it. It's like the thickest. It's so wide, and it's interesting because some people, they have like really thick sciatic nerves. I mean, it's one of those things like if you miss it, you gotta be going out of your way not to find it. So it's like the thickest in terms of diameter nerve in your body. And then the saphenous nerve, this is another long nerve as well. And for these, again, do I want you to know where exactly every single branch of every single nerve is? I'll save that for your graduate schools. For now, just know that, okay, is this part of the lumbar plexus? Is this part of the sacral plexus? Do you know that the sciatic nerve is in your lower limb and not in your upper limb or somewhere in your head? So a lot of these nerves, they give some sort of clue to where it is, like the superior gluteal nerve, inferior gluteal nerve. You're like, hey, these are going to be around my glutes, right? So if you already know your muscles and bones, you probably have you can knock these off your list for now and worry about their exact anatomy when you get to like the lab, or if you're talking about more, if you're going to more advanced classes. But for this class, know generally where they are. Yeah, so let's go talk about that sciatic nerve. So here's that greater sciatic notch. So notice that notch is pretty prominent in your pelvis, right? So again, the sciatic nerve is the thickest nerve in the body, and look at where it runs, and it supplies all these branches over here. So this sciatic nerve is a huge, thick nerve that's right here. And so when you have something called sciatica, this is what happens when you got radiating pain. So it's going from all the way from the spine, because again, it's just branching off the spinal cord right here, which is very close by. And then this radiating pain, yeah, this kind of like shoots all the way along the leg. So this is why the sciatica, people who have that, they're like, ooh, if I've heard multiple things, like they say like, I can't, it feels like the whole thing is numb, or it feels like I've been sitting on my foot, or like, have you ever like sat, especially when you cross your legs, or sat on your legs funny and then you get up, or if you sat on a hard floor and you get up and your legs kind of like, ooh, it feels like my leg isn't there, and you're kind of limping around and people are like, oh, what's wrong? And I was like, no, I just sat on my leg funny. So very similar, but something is like, ooh, this is like a chronic condition. So usually on one side. And why is that? Well, again, if you have one nerve, you have a pair of these nerves, right? So if you're only sitting and compressing one of these nerves, it makes sense that that leg will be affected, not so much the one you weren't compressing. And then, so this is most commonly caused by compressing these nerves. So again, your nerves don't like being pressed. They don't like being compressed because that affects their functioning. And also things like our intervertebral discs, and remember our herniated and bulging discs. This is one possible cause. And spinal compression as well. So your spine, like, remember that this is your lower limb, right? So you have all the weight of your upper body on your spinal column. And this can also cause compression of the nerve itself. And piriformis syndrome. So some textbooks, I mean, I've seen some experts and textbooks almost consider sciatica and piriformis syndrome the same. There are related symptoms, and such as like the whole like numbness and pain, but they're not exactly the same thing. So sciatica refers to the nerve itself, but piriformis syndrome is that small muscle in the right over here that we didn't really get to talk about in detail, but now we can talk a little more about it. So piriformis, if I recall correctly, the roots refer to that's pear-shaped, and I'm like, I guess so. I mean, maybe like a very skinny pear. I don't know, but that's where it comes from. And then here we have a normal, what they're trying to illustrate. Here's a normal sciatic nerve. And here's a nerve that's being compressed. Again, this piriformis muscle. So this nerve is running between the bone and the muscle right here. So if this muscle kind of squeezes and compresses this nerve against the bone, that's going to cause a lot of pressure on that nerve, and that's going to cause all the symptoms that are very similar to sciatica. And the other thing is that this sciatic nerve is not only very thick, but also weaves in through many structures. So not just bone, but also between other muscles as well. So sometimes if it gets squeezed between muscles, that can also cause compression. And another interesting example is okay, it's not just weaving through bone and muscle, but there are sometimes unusual atypical anatomies. And do I expect you to know all the variations of the sciatic nerve? Because there's actually many different ways that the sciatic nerve can be arranged with the piriformis muscles and other muscles around it. And one of the interesting things is sometimes it can actually form pass through the muscle. So here it's actually the piriformis, or the sciatic nerve is actually going through the piriformis muscle. So kind of like a little loop kind of weaving in through each other. It's rare, but sometimes that happens. So what happens when this person contracts their piriformis? Well, that's going to cause all that pressure on this part of the sciatic nerve. So sometimes there's multiple things that this piriformis can do, even though it's part of our body, somehow pressing and compressing the sciatic nerve and causing all these pain and also loss of motor function as well. Because again, this is a mixed nerve. It's both sensation and motor. And let's do a quick poll. So I'm going to play a video. So one of this person's leg or feet, there's something wrong with it, something affecting them. So is it the left foot or the right foot? So I'm going to play on this side. And well, I could open Top Hat, but I'm just going to do a YouTube poll. Okay, yeah, so this is called foot drop or drop foot. And what we saw, most of you said right foot, and then most of you are correct. So this person's right foot is being affected. And here we have the right foot is closer to us in the foreground over here. So let's look at that again. So notice when they walk that their left foot is the toes are going up, but when they walk using their right foot, notice that the top of their tips of their toes, they kind of drag their toes when they lift up their foot, right? So this is what we call foot drop or drop foot. So sciatica, well, this is one thing that we often see with that. So notice that they weren't dorsiflexing their foot. So because we don't really think about it, but when we walk, we don't. This is why we're not tripping over the tips of our toes when we walk, because we don't drag them when we're walking, right? So the thing about the sciatica, well, what can it do? If it's going to affect many of the motor control of the lower limb, including compression lesions of the peroneal or fibular nerve. So the peroneal nerve, what it does is innervate these anterior and lateral muscles of the leg. So if you interfere with these muscles on the anterior of the leg, what happens when you contract these muscles? Well, it's going to shorten the distance between this joint, right? So it's going to bring things closer. So this is why when we walk, we do a little dorsiflexion, and lift up our toes and this part of our foot so that we're not dragging it as we take a step forward. So if you have something like sciatica that's causing foot drop, well, that's what's going to happen. You weren't unable to contract these as much, or they become weak in this area. So this is why their foot drags along, because they're not able to bring up their foot and toes whenever they lift up their foot and leg that they're trying to take a step forward with. Now, how can you treat sciatica? Many things. So you can take typical over-the-counter anti-inflammatory drugs, or you can do a steroidal injection. Muscle relaxants also can help with that as well. And physical therapy and strengthening of core muscles. And notice that it's not just the abs, but also the lower back as well. And why is that? Well, the thing is that if we're able to kind of strengthen the tone of these core muscles, is that maybe we can make it so that there's not as much spinal compression, especially if spinal compression is the cause of the sciatica. By strengthening the core muscles, even though you're not treating like those piriformis muscles directly, by helping to relieve the pressure on the spinal nerves and the sciatic nerve, maybe you can help to relieve that patient's pain. And you can also, then this one is under debate, and I think chiropractic in general, some physicians, they don't believe, they still think it's kind of like, they think it's voodoo for whatever reason. I think chiropractic, it's gotten more evidence-based, and I think, like, I don't know any chiropractic doctors myself, so but peer review about whether chiropractic treatment alignment it can actually move this nerve, that's kind of like the big contentious part of the debate. But whether it's helping people and helping relieve the pressure on the sciatic nerve, there are some studies that say like, okay, chiropractic alignment did seem to improve overall pain and quality. Now, is it going to move that sciatic nerve completely out of place or back into place, or move it out of that piriformis? That's the part they're still kind of trying to debate. So, I mean, if it's patients experience better relief, I think it's like that's where the bulk of the evidence is right now. But yeah, maybe it's not a permanent fix, but if it's pain relief, then that's quality of improvement of life. So, hey. All right, so another condition is peripheral, what is peripheral neuropathy? So basically, in general, this is some sort of damage to the nerves of the peripheral nervous system. So nerves that aren't part of the brain and spinal cord being damaged. Now, why I bring it up? Well, is it just one disease by itself? It's just a general condition, and it has many possible causes. So don't think it's just like just one disease that's by itself. So many things can cause it, like trauma, lesions, some sort of injury, or vitamin deficiencies like B vitamins and E vitamins, lack of those, especially vitamin E. Vitamin E is a powerful antioxidant, and your nerves are always generating these chemical compounds called free radicals, or actually all your cells are, but especially your nerves, since they're actually very metabolically active. Infections and diseases can also damage nerve, and so can alcohol. Like alcohol, if you have high concentrations of that also damages nerves, and especially diabetes mellitus and type 2 diabetes mellitus. Yeah, when you have a high blood sugar, that damages actually many tissues in your body, including your nerves. So any sort of nerve damage can result in peripheral neuropathy. Now, why do we care about that? Well, thing is that remember that most of your spinal nerves are mixed nerves. So sensory symptoms include like a loss of pain or sensation, or numbness and tingling can be an alteration or loss in these sensations that you would feel. Or sometimes you might get sensations that aren't supposed to be there, like pain when there's not really a real painful stimuli. So sometimes it can be things like these neurons firing off when they shouldn't be. So say you're at room temperature, but it feels like you're freezing or feels like you're having searing pain. That's abnormal, right? So you can get symptoms that are causing abnormal sensory feelings and motor symptoms as well. Because again, mixed nerves are both sensory and motor. So you might have a loss of motor control in this area. So you may have weakness of the muscles that are innervated by a peripheral nerve, or sometimes in the lower limbs. What can happen is that you can have a lack of coordination and falling. And this is why I bring up diabetes mellitus, because if you've had someone who, or a loved one who has type 2 diabetes, you might notice that they might have like bruising in their lower limbs, or this is why they often have to, like, especially if you're a physician or a nurse and you're treating a patient with diabetes mellitus, you have to really look at their lower limbs, because if they don't feel pain as much as someone with normal nerve function, what happens if they step on something and it's like a rusty nail, and then that causes an infection, and they're not feeling the pain from the infection due to the sensory symptoms. And motor symptoms as well, lack of coordination and falling. So this is also like something you might see with somebody who has like, or like my father-in-law, he has like peripheral neuropathy, and when he walks around, he says it's kind of like feeling like he's walking on water with plastic bags strapped to his feet. I mean, it's like weird sensations, and he tends to fall over now because he has not only just altered sensation, but also reduced motor control over his lower limbs as well. And then, how do you treat that? Well, many things. Like, can you go in surgery? Well, that's kind of risky. Typically, you try to treat just like, okay, work around the symptoms. So pain relievers if they have a lot of pain, topical treatments like, and the other pain relievers like capsaicin creams or lidocaine patches that help to calm the nerves and prevent the nerves from firing off, or antidepressants. Anti-seizure, these are interesting because remember the GABA, that's the primary inhibitory neurotransmitter. So sometimes you might want to, if you have like this searing pain due to neuropathy, maybe you want to give them something that helps to calm down the nerves and reduce the chance of errant action potentials that aren't supposed to be there. Diabetic neuropathy, so off type 2 diabetes, this is off a big cause, or the causes of type 2 diabetes is pretty complex, but one big factor in diabetes mellitus is weight and lifestyle, like dietary management, and also you're managing someone's body fat and weight. That's also a way to kind of like, those are big factors in diabetes mellitus. So one way to help the symptoms is like, you don't want their blood sugar to be skyrocketing all the time. You want to make sure their blood sugar is controlled with insulin, and maybe make things easier for them overall by kind of managing their weight and lifestyle. Medication to treat the numbness. Yeah, that's the tough thing too, is like restoring function is still where we want to do. There's a lot of research that needs to be done. So they might prescribe other things that help with like neurotransmitters, but a lot of it is like, we can't really, restoring function when it's lost is still, science and medicine is still working on that. So peripheral neuropathy, so many things like the nerve conduction test, you can use electrodes, see the how fast impulses travel across it, because remember, those electricity involves electrons, right? So then what do we have with like the movement? This is why we're able to detect it, because what happens with action potentials? We're changing the membrane potential and the positive and negative ion balance inside and outside the cell, so we're able to actually measure this rate of impulses with these electrodes and these nerve conduction tests. And so this is why we also have electromyography, the same image again. And what's another way we can do? Somatosensation tests. Somatosensation, so here to review, like pretend this guy, like he gets an injury here, or he has peripheral neuropathy in this case, and say these nerve endings, they're non-functional or they're dead. And so what happens if you try to like take something like a cotton ball and rub it along this dermatome? It'll be like, I don't feel anything. Or if there's damage and are signals still able to be passed along these nerves, but say they fire the wrong type of signals. Instead of light touch, maybe they're sending signals of searing pain, even though we just have a light touch of a cotton ball. And he's like, ooh, ow, ow, ow. And you're like, ooh, maybe I pressed too hard with that cotton ball, or maybe this cotton ball is made out of ground glass. Well, again, what's another way you can check your work? Do the same part on the other side that's you think is unaffected. He's like, oh yeah, this is a light touch of a cotton ball, but this side is super painful. Yeah, maybe he has peripheral neuropathy along this T1 spinal nerve on his right side. So how else can you check? So there's many ways you can check. You can use that electromyography, you can nerve conduction tests, you can use some sensation tests. Another way you can do is check on the motor function. So those were sensory. So we were talking about electricity over here, and this was and there were an action potentials itself, and we're talking about sensation in this test over here. But we can actually check on it with a motor test. So let's see. Oh, the research project on the effects of aerobic exercise to treat peripheral neuropathy. That's so cool. Yeah, if you have an update on that, that would be really cool if you finish that study. Every treatment for disorders and syndromes. So every treatment, I think that's more like FYI. But the main thing I want you to see is a comment, like the specific treatments, not so much like, okay, I want you to list off all the medications that we covered. Unless I make a big deal about specific medication, probably not. But the big theme with those nerves, again, peripheral neuropathy is a very general term describing a symptom we see or any sort of general damage to the peripheral nervous system. So what you can see with all those treatments is that they're affecting either like nociception or or neurotransmission itself, rather than actually repairing the nerves or growing new nerves. So with our current technology, we're not actually able to like repair the nerves itself. We have to kind of work around. So either blunting their function, especially if there's excess pain, or doing other things to try to help with the neurotransmission as well. Missed a question. Is that transverse ligament connected to piriformis? Yeah, it's connected to the piriformis, and it also spans that from like medial to lateral, right? So it's also going to insert onto the scaphoid, and also the trapezium and the hamate as well. So, but do I want you to know the exact insertions? Not too much, but it kind of just spans if you had your whole carpal bones, it does span like that. So how else can you check? So we talked about sensory checks. Now how about we check the motor function? And this is where reflexes come into hand. So one way you can do is check this person's reflex. Now what is a reflex? Well, a reflex is, when we think of something being a reflex, we think of it as something kind of like you do automatically without really thinking. And that is kind of like what a reflex is. So here's a painful stimulus, right? So this person has a hot pan, and for whatever reason, they're doing it for like whatever TikTok, or they're doing for IG, they want views, and they touch this painful thing, and they're like, ooh, ow. So how do we pull back? We don't really think about like, okay, we touch something painful, we pull back. But why is it so quick? Well, the thing is that we have this stimulus. It is a change in our environment. We're going from normal room temperature, touching something super crazy hot, right? So this signal is going to transfer along a sensory neuron, or sometimes like sensory receptor. And again, this is where it gets a little confusing. Sometimes you might see in the book it's referring to the receptor as the dendrites that detect the stimulus itself, or sometimes they're talking about the entire cell. In this case, I'm talking about entire cell that serves to conduct or transfer the signal from the stimulus to your central nervous system. Now here's a cross section of the spinal cord, and what we have highlighted over here is an interneuron. So this interneuron actually branches. So here's the cell body. It's receiving you can't see the dendrites, but it's receiving the action potentials and neurotransmitters from the sensory neuron, and it's going to send signals and action potentials along its branches over here. So we'll ignore this branch right here, but notice that it's synapsing on two more neurons. So these two neurons are going over here. Well, one is a direct synapse and one has another interneuron here. But what happens is that these signals along this interneuron is going to activate these motor neurons. Now there are different color coding, and again, this red and blue stuff, it's not like canon. It's like sensory neurons are always red, motor neurons are always blue. This is like just how it's depicted in the Martini book. So don't get confused with that. But with this motor neurons, what happens? Well, remember motor neurons, are part of a motor unit, and a motor unit involves muscle or a neuron and muscle, right? So here we have two skeletal muscles that are innervated by motor neurons. And there's going to be that neuromuscular junction that releases acetylcholine. We covered that already. I won't go into the specifics. But the big difference with this one is that we have a motor neuron that's stimulated and one that's inhibited. So it's due to this, so sometimes you can have signals passed on that stimulate other neurons, motor neurons, or you can tell there are sometimes you can send inhibitory signals that kind of puts the brake on a motor neuron. So this one in the black right here, they're going to stimulate the flexors of the forearm at the elbow. So such as your biceps brachii and brachialis as well. So what happens when you contract and stimulate those flexors? They're going to move your biceps that way, right? And not only do you have that, you also have inhibition of your extensors. So if you're touching a hot object, do you want to extend? Because what happens when you do a triceps extension if you're doing it at the gym? Or doing a triceps pull down or push down, right? So you're trying to do, have you ever done that? If you go to the gym and you try working your triceps, where you do that exercise, you hold on to this and you extend your triceps. Well, what are you going to do when you touch that hot object? Do you want to extend and double down, put your hand even further on it? Or do you want to move it away? So it makes sense that you want to prevent your extensors, such as your triceps, from extending further. And it makes sense that you want to contract those flexors that move your hand away. So this is why when you stimulate the flexors and inhibit the opposing muscles, this is why we have that withdrawal reflex. So that's what we have here. So this is what happens when we touch something painful. This is why we kind of flinch away. It's due to this reflex arc. Now, over here, what about this branch over here? Where will that go? It's going to go up the spinal cord and go to your brain, because do we just go flinch back and we're like, oh, okay, that was nothing. No, when we touch something hot, we're like, ooh, ow, right? So the thing is, this is part of that parallel processing. You have this interneuron sending signals over here, telling your muscles, hey, pull that back. But you also have neurons, these branches sending signals up to the brain that says, wow, that was really hot. But with this reflex, do we touch that hot object and we're like, I guess this is hot. Maybe I'll take it off? No, it's almost automatic, right? So this is the cool thing about reflex. You have you have sensation, you're detecting a stimulus, but it's bypassing the brain altogether to cause that effect where you withdraw. You don't even have to think about it because it actually doesn't reach your brain until later. So this arc right here, no brain involved. So this is what that reflex is. And again, you don't want to have to wait for your brain to say, okay, do the withdrawal with something that's very painful and can cause further damage the longer you hold on to this pain. And here's another example. Say you're stepping on an attack or a Lego or something painful. So here's a painful stimulus, and it's going to do a similar reflex arc on the same side. You encounter pain, you want to withdraw from that pain. So you're going to have the withdrawal reflex on that. In this case, we have the right foot, right? And the right leg. So that right leg is going to be withdraw and do that similar withdrawal reflex as we saw with the arm. Now on the other leg, now this one's actually kind of hard. I think there's some ways it's one of those things that we don't really think about. And I've seen demonstrations on how to do this reflex, but I don't know, it's kind of hard to artificially do it in my opinion. But in this case, what we have, instead of when you step on a Lego, do you jump up with both legs, or do you try to yank both legs up? Well, what happens when you try to yank one leg up? You want the other leg to kind of balance out, right? So this is what we call the cross extensor reflex. So instead of in this case, what we have is the flexors being stimulated in the hamstrings in the right leg. So you're able to bring up your whole right lower limb. Over here, what you have is that now we're extending it. Instead of contracting the hamstrings, we're going to contract the quadriceps, and we're going to try to extend the knee. So this makes sense because if you're yanking up one knee, you want to balance on the other leg, right? So you don't want to be like have like no let that other leg go completely lax, because that is causing some sort of momentum and force here. So you want to counterbalance it. So what if that reflex didn't have opposite limbs? So here we have the same stimulus, but it's causing different reflexes in different limbs. So the whole purpose is to kind of do a coordinated response in both limbs. Because what if you just yanked up that leg and didn't have any sort of like tension here in this left leg? You probably would like kick up that leg and you kick up your right leg and the other leg would just topple. So you want something, this is what the cross extensor reflex helps to do. It helps to maintain your balance. And let's cover yet another reflex, and this is another reason why I miss in-person classes, because like I always love doing this, because using the reflex hammer and trying to do the patellar tendon reflex. And what we have is a stimulus. So what's going to happen is that you take a reflex hammer and then you're going to hit this tendon right here, right? And what's going to happen is that when you hit this tendon, it's going to draw all of this closer to that when you hit that area you hit with the reflex hammer. So when you do that, that's going to actually stretch this muscle. And when this stretches the quadriceps group, what it's going to do is going to activate these stretch receptors. And these are the muscle spindles we talked about in a previous lecture. So when these are stretched, and these are mechanoreceptors, so when they get stretched and have some distortion in their membranes of their cells, this is going to send signals along these neurons. So the muscle spindles within these fibers, they're going to send signals along these sensory neurons. So yeah, and then the sensory neurons are going to synapse onto motor neurons, and these motor neurons are going to innervate the same muscles, and here we have the quadriceps muscle. So these motor neurons are going to stimulate the contraction of this muscle. So what happens when you contract your quadriceps? What is it going to do? Let's see how much time we have. Okay, if you contracting your what to the knee joint, extend, flex. Let's do a quick quote. So we're activating these motor neurons and stimulating them. They're innervating the quadriceps group. What do you think that's going to do to the knee? Is it going to flex it or extend it? So again, if this is like, or let's see, if this, I know I'm using the camera. So if this is like your knee joint over here, is it going to extend or is it going to flex it? Okay, let's end the poll. So most of you said extend. So what's going to happen? If you innervate these quadriceps, it's going to shorten, right? So when it shortens, it's going to pull this, shorten it, and pull everything closer to it. So what happens is that when you have this contraction of the quadriceps, this is going to be the response. It's going to draw this lower limb and your lower leg. It's going to draw the tibia and fibula up closer toward this area over here. So it's going to stretch out and extend that joint. So it's going to cause extension of the knee joint. So this is the reflex arc. And hey, do we have any brain involved in this? No, notice that all the fibers were just going straight here, synapsing on the motor neurons, and then causing contraction. So this is what we call the patellar reflex, or you might have heard knee jerk reflex. It's more than just an idiom. It's talking about this particular reflex. If you ever had this done at the physician's office during a physical exam, you might say, oh, it kind of feels weird. And yeah, because you're thinking like, oh yeah, I didn't really, like my knees automatically extending and starting to kick up. And why is that? I mean, I didn't even want to do this. Well, that's because it's a reflex that doesn't involve your brain. Now, this is also why they might try to kind of like distract your brain. Maybe they might tell you to do the Jędrusik maneuver where you do this, what they call reinforcement, or they might ask you to count out loud. They might try to distract you. Because, yeah, even though reflexes, arcs are automatic, your brain can still send commands to your motor neuron. Like if you want to be difficult, and please don't do that to your nurse or doctor, you might try to contract your other opposing muscles, or try to do this, kick exaggerated, or do something like that. That's not the purpose of this whole thing. It's trying to test whether there's any potential nerve damage along these routes. And what's something else you can do besides the patellar reflex? You can do the plantar reflex or the Babinski reflex. So the plantar reflex, what you can do is like with that same reflex hammer, I wish I had it with me right now, and now this looks sharp, but it's not going to stab you, but it's like it does have like a little bit of a point, but it's not like something super sharp like a needle. So what they do is take this, the other hand, not the reflex, not the mallet part, and they kind of like scrape the handle in this. There's different techniques, but this is a common one. So you're going to take that on the sole of the foot and scrape it. You don't want to like totally jam it, just enough so that this person can feel that kind of hard metal object being dragged along. So what would happen in a baby, so this is a healthy adult response. So the healthy adult response is to kind of curl your foot away from it. So you have this hard thing kind of scraping the bottom of your foot. So if you see the toes kind of curl and kind of round, so it's kind of like, kind of withdrawing away from it. So this is a healthy adult response, or a negative Babinski sign. What happens if these toes start splaying out outwards and upwards, or if you had the foot start to dorsiflex, that's when it's kind of weird, and that's what we call a Babinski reflex. But the interesting thing is that as we age, if you try to do this on an infant, they will splay their toes upwards and outwards and make their foot go this way instead of like this way. So that's healthy in infants, but abnormal in adults. So this is what we call a Babinski sign. So I like to think of it this way, the Babinski reflex. So you might be like, oh, this is an interesting last name. So I like to use this mnemonic, baby in skis. So Babinski sounds like baby in skis. And which way do skis point up? They don't point into the ground, right? They point up away from the ground. So if you have a Babinski reflex, it's going to go upwards and outwards. So this is why the skis point upwards, same with the toes in the Babinski reflex. And again, this is a baby, right? So it's normal in babies, but you don't want to see this in an adult because this might indicate nerve damage. So the typical reflex in adults will be, again, it's going to arch away from that edge. Okay, so why might this be useful? Say someone has like really meaty kneecaps and knees, and I don't know. I swear, I've only tried it twice. Actually, I love picking out like someone who runs track or one of those agility sports, because I noticed that they had great reflexes. Like whenever I used the reflex hammer, they would like super kick. But sometimes, like one time there was like a football player, and I swear, I think he was just too thick, and then I was trying to or maybe his tendons were just too strong, and I had trouble stretching his quadriceps with this the reflex hammer. So but I'm like, okay, he's walking around, he's got to have a reflex. So if someone has a hard to find patellar tendon, or you're just trying to whack away on that and they're getting super annoyed at you, maybe go downstream. Go down to the foot, try to do the Babinski reflex. If it's normal, then you're like, okay, if the nerves are normal down here, they're probably normal up here. So that's one way you can do that if you're having trouble doing the patellar reflex. So yeah, if this is all normal over here, it's probably normal up here, even if you're having trouble doing the patellar reflex. All right. Okay, it's Friday. Let's call it a day and call it a week. So thanks for everyone who's hung on. Thank you to our moderators, and I'll see you on, let me check my calendar, because I know one Monday I have to actually handle something at the med school, but I'll let everyone know if I have to do a pre-recorded stuff. But yeah, see you on Monday. If not, there'll be recording.